So good morning, everyone. Let's get started because we are already on time. First, thank all of you for joining us today, and maybe start with a brief contextualization. The question for today's webinar is a simple but provocative one, which is: are we wasting the potential of health data? So across Europe, we are investing heavily in data infrastructure, AI initiatives like the European Health Data Space. Yet, in practice, many organizations still struggle to turn data into real value. So the quick question is not whether we have data, it is whether we are actually able to use it. So in this webinar, we will explore the secondary use of health data, the development of European health data spaces, and basically what it takes to move from ambition to real-world implementation. This discussion is particularly relevant in the context of the HELIX project, and I will also like to take this opportunity to briefly present the scope of the project. So this is a European initiative that aims to enable secure, privacy-preserving access to distributed health data through federated learning and cloud AI. So HELIX connects health data holders and secondary data users without requiring data to leave its original location, so federated model, addressing key challenges related to trust, interoperability, and regulatory compliance. I'll leave a link with additional information in the project below if anyone is interested in checking as well. And today's session is structured around a roundtable discussion that brings together different perspectives across the health data value chain. So starting with the introductions, we have Daniel Beirão, which is a family physician, deputy medical director at Hospital da Luz in Portugal, and invited professor at the Faculty of Medicine of the University of Porto. Daniel brings the perspective of data providers and ecosystem enablers with clinical and also organizational insights into how health data is generated, structured, and used in real-world healthcare settings. We have also Michael Dybowski, the president of Global Healthcare Travel Council and the president and co-founder of the Healthcare Poland Foundation. Healthcare Poland is a HELIX partner project. So Michael, it's good to have you here. Michael brings the perspective of regulatory alignment, policy frameworks, and the conditions needed to enable trusted secondary use of health data. And we also have Luís Marco Ruiz, a senior technical consultant at Vitagroup. Vitagroup launched this challenge to have this discussion with different players. And Luís brings the technology perspective, so focusing on architecture, infrastructure, interoperability standards, and technical requirements that are, of course, needed to make secondary use of health data scalable and operational. So thank you all for being here today. To start the discussion, I would like to begin with a broad question to set the scene and understand where we stand today. So where do you see the biggest gap today between ambition of initiatives like the European Health Data Space and HELIX and the reality on the ground? Maybe Daniel, I'll start with you. From your experience in the hospital setting, how far are we from being actually able to use data beyond primary care purposes?
Thank you. Thank you all for the invitation and for being present. I think the biggest gap is between European ambition and clinical operational reality. And I will be quite direct on this. The ambition is right. European health data space is necessary. Federated approach, such as those explored by projects like HELIX, are very relevant. Of course, artificial intelligence will increasingly depend on access to high quality data, but for the majority of healthcare organizations, this reality is still far from that ambition. not because organizations do not understand the value of data, not because clinicians do not care about this data, but because this health data is not born ready to be reused. Health data is born inside clinical workflows. It is created during consultation, emergency episodes, hospital admissions, diagnostic process, clinical notes, and so on and so on. And the most important part, it is created under time pressure. So in systems that were designed primarily for documentation, billing, and legal traceability, and for operational workflows. So not necessary for research, not for artificial intelligence, and not for secondary use at European scale. So the first point I would like to make is this: digitization is not the same as data maturity. So having an electronic health record does not mean you have reusable data. Having a data warehouse does not mean you have clinical meaningful data. Having access to a large number of data does not mean having data that is ready to support research, AI, policy, or cross-border secondary use. So this is where I think this gap is mostly visible. At European level, we speak about the data space, secondary use, real-world evidence, federated learning, cross-border data access, innovation ecosystems. But I think inside many healthcare organizations, we are still struggling with very basic issues. Data is often unstructured, coding may be inconsistent, for information is fragmented across systems, clinical concepts are not always standardized, important outcomes are not systematically captured, and most of the valuable clinical reasoning remains locked in free text. So from the perspective, from a provider perspective, the issue is not only can we access data, the more fundamental issue is, can we trust the data? Can we interpret it? Can we compare it? Can we reuse it outside the original clinical context without losing meaning? So that is why I would like to summarize this gap in one sentence. I think that availability is not the same as data readiness. So, and I would go one step further. Data access without data readiness may simply scale poor quality evidence, and that is a big risk in healthcare. So we may become very efficient at connecting data sets, and these settings are not yet mature enough to support the decisions we want to make. For example, a diagnosis code may not tell us whether the diagnosis was suspected, confirmed, active, or even if historical. A medication list is not telling us whether the patient actually took the medication. So if we take the data and use it for AI, benchmark, research, or policy without understanding its limitations, we may create an illusion of precision. And in healthcare, that is very dangerous. So data can look objective while still being clinically incomplete. So my answer to the question is, the biggest gap today is not only between policy and technology, it is between the ambition to reuse health data and the reality of how health data is produced at the point of care. So my first message will be, Europe is building the infrastructure for health data, but we need to make sure healthcare organizations are ready to produce that data that can carry that ambition.
Thank you, Daniel. So data readiness is something that I would like to dive into even further, because it's for sure a really important topic for data usage. But I will also like to ask Luis, from a technological perspective, if what Daniel was saying also matches the technical disconnection that is felt between European level strategies and what is being implemented in the organizations.
Yes, I completely agree with Daniel, and actually I like the sentence, the data was not born to be reused. And that is completely true and reflects perfectly the problem we are facing. So what we have is, in many cases, electronic health records that were created as document stores for clinicians, let's say, to be able to provide or deliver care to patients and be able to follow them and so on. Some others are better or worse. But they in their inception, the reuse of data was not a priority, let's say. And then we can, of course, move to, let's say, a third generation of electronic health records that are able to store with much more expressivity a longitudinal view of the electronic health record. But there comes a challenge. We then, at the point where we produce the data, this means when we deliver healthcare, what we see is we can do that to a certain extent, because if we become too, let's say, stringent with the data we want to store, and we want very precise data, we face several problems. The first one is usability. And as Daniel pointed out, this is a very pressurized environment. So the design of these systems needs to take into account let's say, the user perspective and reflect that. And this will mean that we will need new tools and new developments towards making possible storing high quality data, highly precise data, but also without, let's say, imposing extra burdens on the clinical side. And this is one of the possible, let's say, uses of AI. So we can potentially use AI, let's say, with nowadays there are many applications like for listening while the consultation or the encounter occurs, and try to help the clinician with storing this data in a more, let's say, precise manner. Also, it's important to recognize that not always all the data we want to store for a specific encounter is available at the time of the encounter. So we also need to come up with some flexibility when it comes to producing these kinds of data. So that's, let's say, the main issue I see, that we need to maximize data quality from the point of, let's say, not missing data. Data should not be ambiguous. It has to be precise, uniqueness, and all these quality measurements. And then let's say, the second challenge I see is that the infrastructures are not yet prepared in more stringent, let's say, legislation, such as in Germany. Not all hospitals are able to, for example, have a circuit for data reuse where you can actually make an efficient processing of the patient consent, and let the patient also select what kinds of data he or she is willing to share for secondary uses. So we have implemented some of these projects, but it's not many hospitals that are actually able to do this in a, let's say, a legally compliant manner. So this is another important challenge I see for data reuse.
Thank you, Luis. That's a really interesting perspective as well. So there's another really important topic that comes into place, the regulation and policy perspective. So, Michael, do you feel that the current frameworks are enabling or slowing down implementation of European Health Data Space secondary use of data?
So obviously, thank you very much. And the beginning of confirmation is to state that there is a lot of data that needs to be first structured, organized, processed, and then aligned into being fed into some kind of system that will allow later on to operate on that data. And as we all know and we all understand, the ability to deliver that data across the board, looking on the European Union perspective, it's not something that could be manually done by humans, so to speak, but we're going to be probably looking, and we're all sure about it, through the means of different technologies and solutions which are already there. Well, obviously, one of them is artificial intelligence. Some of them could be automation. It doesn't need to be AI on every round, but at the end of the day, to do and have constant the reasoning comes AI, and we're all aware of that. Besides, Helix is also concluding some of the solutions which will be showcasing that. Now, for this purpose, it comes into framework a couple of European legislative manners. And obviously, here comes the Data Governance Act, here comes the AI Act, here comes the GDPR, and many, many, many others. So if you look on this level of multiple assets that are being showcased that really are relevant to managing that data, and adding on top of that the layers of individual countries, which are having their own rules and own ways of dealing with all those regulations, so pan-European regulations, and you got the local regulations, and some of the individual healthcare units, they do have their own local specific regulations based on how they want to handle that data. So if we're touching, this realm of sort of multiplicity of end-going solutions, we definitely are facing a massive wall that we're trying to drill through to get access to the structures of the data within the individual units, and then having that data to be available to be trained on, and how to get the information out from the data models that are being implemented there. Now, obviously, as my colleagues before said, there are multiple issues, right? So we're starting from if the data is even structured, right? So we know they're not everywhere and not to the same standard. Then we have, is the data interoperable? Well, not really, because if it's not structured, the usability of it's very, very limited. We have a situation in which some of the healthcare providers are in the HIS systems or vendor lock modules when they are not able to actually easily pull out all the data from their HIS system, from their own systems, to get into the secondary use space because it's just been limited by the vendors. But here comes the legislation with the help that will enable in the future, while it's getting implemented in more and more countries, to enforce on those vendors some unlocking of some of the processes. So it comes with obviously multiple tiers, and seeing the regulations on one hand, it could be very helpful because it then relieves the pressure from the individual governments on having to speak to the manufacturers of the healthcare systems into, getting the openness and accessibility of that data, because the European regulation is on top of that and is sort of enforcing that as a whole, 27 states mechanism. And then the local government is only implementing it in a matter that opens it up. So this is the support. But on the other hand, if you're looking on the GDPR and some of the limitations that are being very strict in certain countries, then it seems that without having an individual opting in for sharing that data, you might not be able to get any access to that data, even if you try to synthesize it, because you're not allowed it to synthesize that data in the first place. So obviously, within the project and within the scope, the loss of the opportunity is tremendous. We do lose the ability to use that data for multiple purposes, either if it's statistics, if it's public health, if it's research, if it's academia, if it's models triggering for different developments of even rare disease, treatments or whatever, the protocols. So from the perspective of the humanocentric approach, there is a massive thing that we could do with that data, and that's something that I'm very happy that is being now recognized. It's part of what we're doing really in Helix and in this whole project, that we can try to build a module in which it could be enabled. Obviously, we have to go through the burden of going through each individual legislation, through merging it up to the European level. So it's usable, it's transferable, it's transparent, and then it's trustable. So the approach with federated learning is the key element to that. And from the compliance and policy viewpoint, we find it the most attractive element, where we do have the actual zero trust policy by design in this module, that allows the federated learning to allow for those who might not know that the algorithm goes towards the source, it learns that, and then it just comes back without actually shifting or moving the actual data. And that's actually, bypassing all the strict or supportive regulations in such way that is compliant with the standard law for all the member states, which has been already identified, and it's supporting the actual development of the policy itself. So by those means, we have, we have the obstacles, but our role is to be inventive, and that's what this project is all about, that we can deliver the solution that is actually finding a path forward despite some limitations. But other challenges, of course, they are, and I would be a liar if I would say differently. So the obstacles will come, but seeing the great work that's been put forward and this roundtable discussion being an example of that, where we all actually are confirming and sharing the perspectives, is actually the thing that is moving everything forward.
Yeah, thank you so much, Michael, for bringing this point. It's in fact a really complex theme. One of the ideas that I think came across most of the discussions and the interventions that we had today is related to data availability, the data being ready to use. And I wanted to kind of explore that in more depth. What does data readiness actually mean in practice if we want to enable the secondary use of data? Maybe I will ask a question to Luis to provide a technical perspective. What are the technical mistakes organizations usually make when trying to prepare data for secondary use?
So yeah, I wouldn't call it a mistake, because in many cases it's not a mistake. It's just that they are dragging, let's say, lots of technology debt for different reasons, and legacy applications. So what I would say, and coming back also to what Daniel expressed at the beginning of the workshop, which is also related to federated learning, which is we need to maximize data quality and semantic precision at the point where we capture the data, because otherwise we cannot do any type of reuse, and that includes also federated learning. For example, if we have divergences between the sources in the way of coding ethnicities, because, for example, one source is coding ethnicities and the other not, then algorithms cannot perform optimally, let's say. So to that end, and this is one approach, we believe we need to be able to store the data at the point of when it is produced in a, let's say, very semantically rich way. So to that end, we rely on OpenEHR. So we don't have, let's say, a proprietary model. And we do believe that we need to store this data when it is produced in OpenEHR, because it allows also the longitudinal view of the full electronic healthcare record and the patient journey across the healthcare system. Now, that said, this involves also a lot of compromises you have to make, which with regards to governance. So you need very high quality models that need to be governed, and they need to be shared by all the organizations participating in data reuse, let's say. So to that end, that's also very, very important. And a second, let's say, point I would like to highlight is when we think in, let's say, in 2030 something, when we have or we should enable secondary use of data at the European level, we should not think anymore about patient summaries, but we need to think in data that is very complex. And you can think, for example, in Alzheimer's disease research, where you have biomarkers, you have very complex neuroimaging reports, and this data is actually evolving all the time. So just, let's say, agreeing on some patient summaries and basic data sets is not going to do the job for real, let's say, and complex clinical research. So therefore, we need to think in interoperability by design, if you like, and make sure that we are able to store data with a precise format that allows this interoperability from, let's say, time zero onwards.
Thank you, Luis. Daniel, I would also like to pick your brains regarding this theme, as you first mentioned it, how realistic it is to ensure structured and usable data at the point of care?
I think Luis already pointed a lot of things that are meaningful. And I think when we talk about this kind of need of having a structure, fields that we can use to use it in a clinical setting, I think this we have to make sure that not everything in medicine can be structured, and not everything must be structured. Clinical narrative is essential, free text is essential, but some elements must be structured if you want to have a meaningful secondary use. So I think on the perspective side, on the provider side, when in a healthcare organization, we need to know what fields or what kind of fields we want to structure to have this meaningful. And when I talk about this, I will talk about diagnosis, procedures, medications, allergies, functional status, some of the patient-reported outcomes that sometimes are missing in these data sets. Of course, we need to know escalation of care pathways. If those elements remains only in free text, secondary use becomes much harder. So data readiness is not about eliminating these clinical narratives, about deciding what must be structured, because we have to be on board. We have to know. I would like to highlight also something that we said about governance, because governance is correctly linked with this the way we structure these kind of things. But I would like to add three more things. One thing is clinical meaning. So we also have to, when we, and all of these are linked. So governance, this is the data that we want to structure, but also clinical meaning. So we can have a patient that may be charged as a clinical still, but still have functionality decline. So these dimensions, these reported outcome measures that we have from the patient side, we need to collect them also. But the same thing is about standardization, and Luis also talked about this. We often confuse technical interoperability with semantic interoperability. Some organizations structure fields or want to say something that is different, that they have different meanings in different organizations. So we need to have this in mind. So this requires common definitions, common standards, and a shared clinical interpretation. And I would like to add one thing: traceability. We need to know where the data came from, where is recorded, when, in what setting, in what level of certainty, because this is really important in a clinical setting, and for what purpose. I would like to add something that may also be very important to catch the attention for physicians and for professional healthcare, because feedback loops for clinicians is really important. For me, clinicals will not improve data quality just because someone tells that they need to use data for secondary use, and they will not engage in data readiness only if it's mandatory in some fields. They need, if you want to have better communication into feed these external bases, it has to be a point when the clinical teams ever see a return value, or this engagement will be weak. So what I want to say with this is that data readiness must not be experienced as data extraction. It must be experienced as a better clinical practice. This is what I want to add.
Thank you, Daniel. I think that those are some good points. And Michael, how do you think some of these aspects, such as the traceability, the clinical meaning, the governance as well, are being dealt or incorporated into available regulation, or what are the points that currently are still missing or still need a lot of work involved?
Okay, so there are a few elements that I think we need to, what we already seen from the practical viewpoint. I want to put a contradiction towards a statement that we need more standardization in this way. We don't lack any standards anymore. So what we have to start doing now is we have to start to build more implementation solutions. So it can actually get developed, get pushed out, get tested in the real sort of sandbox, environment, living labs and stuff like that. So that's something that we need more of, that's for sure. Are we I'm just thinking from the perspective what the gentleman said, beforehand, and there's a lot of connecting points that there's definitely more of the requirements on the elements that will deliver the proper scientific value to see more of them coming out, so it could be more used and get things to be pushed out as one of the means of delivering the actual value itself. So that's definitely something which is the key element. We got to start thinking about, what are the puzzles, but actually start doing things. I think from the perspective of all the healthcare systems we've seen so far, right, a part of multiple projects we across, we see that from the health data perspective, especially for the secondary use, the push out of solutions that can aggregate, properly tag and deliver, that's the highest demand right now. So from the naming of a previous sort of revolution in approaching within the industries as such, which are eddies, for those projects where we don't deal with medical records, but we do with the industry itself. We've seen that the more connectors, the more platforms of deliverance, the easier the project can move forward and the access to that data. So from the perspective, I would say what we need definitely more, and answering your question directly, is more deliverables, more things going on, more actual testing, and more openness in the frameworks to allow for that by each and every individual, European member state as such. So this is the real go-to thing from the perspective how we're perceiving it on the level of Healthcare Poland, but also the global healthcare systems hubs, and what will that also create? Talking now with the hat of the medical tourism as well. If we're looking of patients moving around and then use of their data to follow them, that's another great enabler of solutions to be provided with that realm as well as a value added thing.
Thank you, Michael. So assuming we solve the data quality challenge, I would say that the next question would be how we scale this. So what does it take to make secondary use of data scalable across organizations, regions, and countries? Here we have the representation of 3 different perspectives, but also different countries. And Danielle, you were saying, I think, a really important topic that we are always discussing, which is how do we engage healthcare professionals? So we need to demonstrate the value. It's not enough to simply say that we have to comply with the European Health Data Space and with the secondary use of data, because for many people that doesn't actually mean anything. So from a provider perspective, what would make organizations more willing to participate in these large-scale data ecosystems?
I think the first thing that comes to mind is trust. Trust in a way that, of course, in the patient's perspective, so they need to see that this data is protected, but behind that, or even more important on the healthcare organization side, they need to trust that participation in these kinds of processes will not expose them to unfairly or create obligations without the support. So this is a very practical issue on our organizational side, not only because of legal sensitivity, but also because of clinical sensitivity, ethical sensitivity, social sensitivity. If people do not trust the system, they will resist to it. We of course talk about governance and the clear rules that we need to have it. I won't repeat it again. Without, of course, the semantic interoperability I already discussed. But I will also like to add the provider capacity. This is often underestimated. So healthcare organizations cannot be expected to prepare data for secondary use without resources. So data readiness requires people, clinical stewards, interoperability experts, cybersecurity teams, legal and ethical support. And this is not free and it's not automatic. So if you want that, we need more than we have right now in healthcare organizations. And I think the last one, the most important one, is also what I mentioned earlier. How can we engage clinical teams doing this kind of things that we need them to do to be able to scale up is reciprocity. Healthcare organizations should not only be seen as the data providers, they also need to benefit from the insights generated from their data. If these secondary data uses creates value only for researchers, policymakers, and industry, but does not return value for the organization, then the professionals who generate the data, then the model will not be sustainable. And I think this is a key point to engage more on the clinical teams and on the organizational side that perhaps maintains or be able to scale up and be on board with this important topic.
So following up on that, I think I will pick up a question from the participants with a lot of exclamation points. So we know all these issues for many years. Why repeat them? Where are the solutions? So Luis, what do you think are the architectural choices critical to ensure scalability? Are federated environments a solution? What's your perspective on this?
Well, many of them are actually reflected in the legislation. So if you check the legislation for the European health data space, actually the governance part is mentioned, let's say, maybe not always with these words, but it's very well reflected. So, but as I said, we need to make sure that we have this semantic precision, and that's technical part, okay, and we will need tooling for that, but we have technologies to enable this. But then at an upper level, we are going to need also to enable at the regional, national, and European level means for actually governing data sets or data products, however you want to call it. There are some hospitals which already have some pilots. And the governance of these data products is, I think, is going to be crucial. Just reflecting on what Daniel said, that we will need to make sure to tag who was the producer for what intent, what is the specific format, let's say, of the data that composes the data product. We will need to ensure also the traceability, what transformations were performed, because this may affect also the secondary use of the data and so on. So that's from a technical perspective. I think we need to enable better technologies for making an efficient governance of this. And the other one is to enable this mostly, maybe not at the national or regional level, but to really enable this, we need also funding frameworks that directly go to healthcare providers, organizations, in the sense of hospitals, outpatient clinics, and so on. So we did a research, and this was more on artificial intelligence adoption, but it also is the same problem with data reuse in general. And what you find is, yes, we've been funding lot of research when it comes to AI for secondary uses. Let's say at the university level, we find that lots of funds have been available to develop new algorithms, even for SMEs and so on. But when you actually talk with clinicians at the hospitals, what they say is, we are very interested in acquiring AI because we truly believe that it will be a relief on the, let's say, high pressurized environment we have, but we don't have any funding to actually evaluate this within the clinical workflows that we use. And this is the same case for secondary use of data in general. We need to empower them with funding so they can have the resources to actually decide what is the best way in their medical workflows to actually produce better data and to allow them to design what are the best technologies that they should use to that end. And this should be done at the local level. We cannot decide, let's say, at the regional or national level for them.
Yeah, we discussed a lot the role of data providers. I think all three of you pointed that out, and the importance of engaging them, of course, because they are a crucial player on this topic. So, Michael, do you think it's easy for these entities to understand the European health data space, the added value it can bring?
I don't think there is enough understanding. There is still a lot of work that we have to do in terms of communicating. I've heard on multiple occasions that without doing the primary data base, there is no chance of doing the secondary one, which is absolutely untrue. So the discussion's been going around several issues, but I think that three main elements that needs to be addressed, while the one said by Daniel, which is the trust, I think it's the last part of those three elements. The first one being for the actual data providers to start being honest, that the assessment of pretending the data is ready is just false, and we need to actually make sure that the standard of that data preparation is the crucial element. The second one will be the budgeting. So most of the elements within that process are not being addressed by the countries, by healthcare systems. And then there is no budgeting for the actual transformation to go towards it. So we do different bits and bobs in terms of, the digitization, management, but this is very specific. This is very specific issue that EHDS is actually creating duties, and but it does not create the budgets in most of the countries across the Europe, what we're seeing right now. So it's another holistic kind of approach. And then comes the trust. Once these two are being built, so we do know that there is the honesty in data. They are robust. They are the ones we can trust, and there is a funding going towards. Then we have to start building the trust. And whatever Daniel said, I don't want to repeat myself. I fully agree with his approach on that. But these are the benefits. These are the elements that are stopping from everyone seeing the benefits, and the benefits are, as I said at the very beginning in the first answer, it's definitely undervalued now. We don't understand how many trillions of projects you can start with data once you have access to them. You can start focusing on treatments. You can start focusing on management of healthcare systems. You can start actually seeing what are the impacts of people traveling across the Europe. It's just enormous. So like we've been trying to solve the problems of, you remember the calls being going out for the analysis of the prevention and foreseeing the future pandemics. This is the thing. I mean, if we have it live, if we have it operational, you can see that data in real time and have that information straight away. So foreseeing the current and previous health conditions, the systems being ready to foresee and to work on that, the EHDS is a go-to structure that is not being seen and understood in the right manner. So here comes this discussion, which is a part of the education that we're hoping to spread the word to multiple stakeholders, so they can see how great, how beneficial these solutions are and what they can bring to the table.
Thank you, Michael. We already reached our 45 minutes of discussion. So just to wrap up the session, we talk about how the challenge is no longer about only accessing data, but it's about also making it usable, structured. As Daniel was also saying, not every data can be structured, so this is something also to consider. We also saw that it's not only a technical challenge, it requires alignment between the clinical practice, the technological architecture, and of course the regulatory frameworks. Initiatives like the ELIX project aims to address these complex teams by enabling federated access to health data, but unlocking the potential of health data, of course, will depend on the collaboration across the entire ecosystem. So thank you to our speakers for their useful insights, and to all participants for joining us today.
Thank you.
Thank you.
Thank you very much.
Thank you all.